Hello and welcome. Today, we're diving into a common yet often misunderstood condition affecting the urinary system, ureteral reflux, also known as vesicoureteral reflux or VUR. We'll explore what it is, what causes it, how it's diagnosed, and the available treatment options. Join us as we unravel the complexities of this condition. So, what exactly causes ureteral reflux? In most cases, it's a congenital condition, meaning it's present at birth. It stems from a defect in the vesicoureteral junction, the point where the ureter connects to the bladder. Normally, this junction acts like a one-way valve, preventing urine from flowing backward. But if the ureter enters the bladder at an abnormal angle or lacks sufficient length within the bladder wall, this valve mechanism fails. In some instances, VUR can be acquired later in life, often due to bladder outlet obstruction, such as from an enlarged prostate in males or, rarely, from dysfunctional voiding habits in children leading to high bladder pressures. Neurogenic bladder, a condition where nerve damage affects bladder function, can also lead to VUR. Let's understand what happens inside the body with ureteral reflux. When urine flows backward from the bladder into the ureters, and sometimes even up to the kidneys, it can cause a number of problems. First, it increases the risk of urinary tract infections, or UTIs. This is because the stagnant urine in the ureters and kidneys provides a breeding ground for bacteria. Repeated UTIs can lead to kidney damage, called pyelonephritis. Over time, chronic inflammation and scarring from recurrent infections can impair kidney function, potentially leading to high blood pressure and, in severe cases, even kidney failure. Furthermore, the constant backflow of urine can put extra pressure on the kidneys, contributing to hydronephrosis, a swelling of the kidney due to urine accumulation. While ureteral reflux can occur in adults, it's most prevalent in children. It's estimated to affect around 1% of newborns. Children with a history of recurrent UTIs are at a higher risk of having VUR. The incidence tends to decrease with age, as some mild cases resolve spontaneously as children grow. Studies suggest a genetic component, as siblings of children with VUR have a higher chance of also having the condition. There are no specific demographic groups more or less prone, meaning it affects all ethnicities and genders nearly equally. Often, ureteral reflux doesn't cause any noticeable symptoms on its own. However, the most common sign is recurrent urinary tract infections. In children, these UTIs might manifest as fever, frequent or painful urination, abdominal or flank pain, and bedwetting, especially in children who are already toilet trained. In severe cases, reflux detected during pregnancy might lead to the early detection of hydronephrosis in the fetus through prenatal ultrasounds. Some children might experience failure to thrive or poor growth due to the complications of chronic kidney infections. Diagnosing ureteral reflux typically involves a combination of tests. A urinalysis is usually the first step to check for signs of infection. If a UTI is present, further investigation is needed. The gold standard for diagnosis is a voiding cystoarthrogram, or VCUG. This involves inserting a catheter into the bladder and filling it with a contrast dye. X-rays are then taken while the bladder is full and while the child is urinating. The X-rays reveal if urine is refluxing back up into the ureters. Another imaging test, a renal ultrasound, can be used to assess the size and shape of the kidneys and to look for any signs of hydronephrosis or scarring. A DMSSA scan, or dimercaptosuccinic acid scan, may be performed to evaluate kidney function and detect any scarring from previous infections. Ureteral reflux is classified into grades I through V, based on the severity of the reflux. Grade I is the mildest, where urine refluxes only into the ureter. Grade IJ involves reflux into the ureter and renal pelvis, but without dilation. Grade H shows reflux into the ureter and renal pelvis with mild dilation. Grade V includes moderate dilation and tortuosity of the ureter and renal pelvis, and Grade V is the most severe, characterized by gross dilation and tortuosity of the ureter and renal pelvis, with loss of the normal papillary impressions within the kidney. The grading system is crucial because it helps determine the appropriate treatment approach and predict the likelihood of spontaneous resolution. Treatment for ureteral reflux depends on the grade of the reflux, the patient's age, and the presence of UTIs. Mild cases, grades I and II, often resolve on their own, especially in young children. In these cases, the primary treatment is prophylactic antibiotics, which are low-dose antibiotics given daily to prevent UTIs. Regular monitoring with ultrasounds and urine tests is also essential. For more severe cases or for those who experience recurrent UTIs despite antibiotic prophylaxis, surgery may be recommended. There are two main surgical options: open surgery and endoscopic surgery. Open surgery involves surgically reimplanting the ureter into the bladder to create a better valve mechanism. Endoscopic surgery is a less invasive procedure where a bulking substance is injected near the ureteral orifice to narrow the opening and prevent reflux. Both surgical techniques have high success rates. Unfortunately, there's no way to completely prevent congenital ureteral reflux, as it's a birth defect. However, minimizing the risk of UTIs can help prevent complications. Parents can teach children proper hygiene practices, such as wiping front to back after using the toilet and emptying the bladder completely. Encouraging frequent urination and avoiding holding urine for long periods can also help. For individuals with known VUR, adherence to prescribed antibiotic prophylaxis and regular follow-up appointments are crucial for preventing recurrent UTIs and kidney damage. The prognosis for ureteral reflux is generally good, especially for mild cases. Many children with low-grade VR will outgrow the condition without any long-term complications. However, severe cases, particularly if left untreated, can lead to kidney damage, high blood pressure, and even kidney failure. Recent research is focused on understanding the genetic factors involved in VUR to potentially identify at-risk individuals earlier. Advances in minimally invasive surgical techniques, like robotic-assisted surgery, are improving outcomes and reducing recovery times for patients who require surgical intervention. Additionally, researchers are exploring new biocompatible materials for endoscopic injection to enhance the durability and effectiveness of this treatment option. Continuous advancements in research and treatment are improving the lives of individuals affected by ureteral reflux. Thank you for joining us on this informative journey.